Welcome to the PFF Summit 2019. It's great to see everybody here in San Antonio, and for those who are not here, welcome to San Antonio. My name is Anoop Nambiar. I'm one of the co-chairs for the summit. I'm a pulmonologist here at UT Health San Antonio. I'm the founding director of the Interstitial Lung Disease Program, so it's an honor and privilege to be here, and also to welcome our fantastic lineup of speakers. Really wanted just to briefly just mention the purpose of this session, which really is to bring everyone here together who are interested in pulmonary fibrosis, who take care of patients with pulmonary fibrosis, and to learn and listen to some of the top experts in our field. So it's really fantastic that we have these great speakers today. And the idea is that we'll have talks, roughly 3 or so in a group, and then we'll have some question answer after each one, and then we'll have some breaks and then a lunch, of course. And we'll also, I think, a really nice thing is to end with a simulation of an ILD conference that will be led by Dr. De Andrade from Vanderbilt. So I think we have a really great lineup. And I was just going to mention some housekeeping items. So want to remind everyone that you must be properly badged at all times. Your special badge and lanyard for this meeting will not admit you into any other meeting. To attend other events, you must wear your regular summit badge. Also be aware that there's another group in the hotel which doesn't move out until late on Thursday afternoon, so some areas may be busier in shared areas. Other things are, I think, just out of courtesy and respect to our speakers, please turn your phones to vibrate. Restrooms, I think, are outside, and look for the signs, and the exit you can see here. And other than that, I think I really just want to get things kicked off, and we have, it's really great to have Lisa Lancaster here to do our first talk. She's coming from Vanderbilt University Interstitial Lung Disease Program. So please welcome Lisa. Thank you very much.
Thanks for getting up this morning. We've got a lot to go through for all the speakers. So I want to be thorough, here are my disclosures, but at the same time, I want to be cognizant of and respectful of the time. So bear with me. Interstitial lung disease, really tough topic. Over 200 different ILDs. People come to see us and with expectations that we're going to be able to nail the diagnosis, get them a plan, and get it going with that visit. So part of our evaluation is resetting those expectations, having patients understand we've got a lot of complexities to go through, a lot of different things to tease out. I'm a detective, they're a detective as we're going through the process. We've got time limits. That's our biggest concern as physicians. We've got a ton of stuff to go through. And then somehow, in this constricted time, we've got to explain a very complicated diagnosis to patients. So that just starts a very stressful process for really everybody. The patient has concerns. Usually there's the patient, either male or female, they've brought their spouse with them, their family members with them. Generally, if there's a daughter, she's a scribe and taking notes. And they're trying to figure out what's going to happen to our family member. What's the diagnosis? How do we manage this? How do we get back on track with this? What's the survival going to look like? The patient's worried about how their appointments and how this diagnosis may inconvenience their family. And in some cases, patients don't want their families to know, which we have to have a discussion about that because they need support. So we're seeing more patients with this diagnosis, and this will continue. So we need to be prepared to evaluate these patients and be able to tease this diagnosis of IPF and other ILDs out from a very long list of possibilities. So these patients come to us with very nonspecific symptoms, cough and shortness of breath, maybe hypoxia. Now that could be a world of different things. But we're looking for those elements that may suggest interstitial lung disease or fibrotic lung disease, and we're going to go through some of those elements today. We're also looking for clues that may suggest an alternative diagnosis, like heart failure, mimicking interstitial lung disease. We're also looking for rheumatologic systemic diseases that may have an ILD presentation as well. The risk factors, excuse me, that we want to ask about, mostly dust, inhalational exposures, but things such as viruses are key things to think about as well too. We never know the full list, but a lot of research is going into looking at how that could be a repeated stimulus of damage in fibrotic lung disease. Arbitrarily, we put asbestosis as a separate diagnosis, and part of that nomenclature comes from how we designed clinical trials back in the late 90s and 2000s we kind of separated those people out from clinical trials. But likely, in my mind, not really any different from the person who inhales fiberglass or some other dust. So we want to set expectations with patients. And I usually, when the whole family's there, I usually say, this is what the plan is today. We're going to do a good history and physical. I have your records, I've reviewed them with your films, and we're gonna look at them together. But we're gonna tease this out and figure out what clues or what information or testing we need to be able to get all of our information together and make a diagnosis. We'll see what we have today, but very likely we're going to take this information, order some more studies, or get some more records, or whatever is needed, and then with our next visit, make the diagnosis, and then plan from there. So just to bring everything down, people understand what your goals are and what you're doing for that visit. We want to get a very good history of what happened and how they were evaluated. So when did you start getting short of breath? When did you first develop cough? When did you make sputum with that? Who did you go see? What testing did they do? And then where did you go? Did they refer you to a pulmonologist at that point? So a good chronological history gives us an idea of the acuity of the presentation and then what's been done at that point and what records I don't have. We want to make sure we assess for other causes of shortness of breath. Many of these patients come in with multiple reasons for shortness of breath, and I'm looking for some low-hanging fruit that may be something that can be fixed and at least correct some of their shortness of breath, whether it be deconditioning, maybe heart failure, diastolic dysfunction, something that hasn't quite been picked up before, or anemia. Those are the common ones. We have a lot to ask about, but in general, after the chronologic story of what are your shortness of breath, going through the pulmonary review of systems, we'll go through a very thorough rheumatologic review of systems, because when we're looking for ILD, and especially for idiopathic pulmonary fibrosis, we need to rule out autoimmune disease, rule out drug toxicity, and rule out environmental exposures. So those are key elements I want to ask about. I want to also ask about substance use. We'll go over more of that in a little bit, and comorbidities, and we're going to dive a little deeper in a few more slides. Create in your mind a rheumatologic review of systems, and for me, mine just starts, I'm a visual learner, so I start with questions that ask about the head or alopecia and work my way down, and try to be as thorough as possible with that, because those are my clues to any possibility of autoimmune disease. I'm looking for clues in the medical history. Do they have a rheumatologic diagnosis? Has somebody been labeled idiopathic pulmonary fibrosis, yet they have an autoimmune disease? Now, we label that fibrotic lung disease as part of that autoimmune disease at this point, so that's our semantics for that. But that gives us clues about therapy. Do they have inflammatory bowel disease, any malignancy, and had chemotherapy or radiation? Do they have reflux? Are there clues on their CT for reflux or dilated or patulous esophagus? Do they have symptoms of sleep disordered breathing that are common in fibrotic lung disease, mainly IPF, that are beginning to show up in other lung diseases as we study it? Family history. So this is one we kind of expanded, and Dr. Cropsey's going to go over the genetics a little bit, much more in depth later on. But anybody in the family with fibrotic lung disease, a lot of times the only history that we get is that somebody One grandmother had a pneumonia, and she went into the hospital a bunch of times with pneumonia and was never quite cured of her pneumonia, and then she died. That could be fibrotic lung disease or an ILD. We also ask about clues. That's what that bone marrow disease, any cirrhosis as well. Those may be clues for a short telomere syndrome related to telomerase mutation. And we're seeing those crop up in our ILD clinics a lot more common. The other thing I'll ask about that I've listed here is premature gray. I'm beginning to regularly ask about that, and I am really surprised how many people have premature graying in their teens, 20s, early 30s, and family members that do that, and they seem to be coupled on one side of the family or the other. Again, might suggest a telomerase mutation. We look for other causes of shortness of breath because patients don't just die of their pulmonary fibrosis. They can die of other causes as well too, about 40% of the time. And some of those things may be reversible and treatable. So let's look at the comorbidities of IPF and delve at least into a few of them a little bit deeper. So reflux is an important thing to ask about, but the important thing to know here is that patients may not be symptomatic. In a study done by Ganesh Raghu, 90% of a population of IPF patients had gastroesophageal reflux disease by pH probe and manometry, but only 47% had classic symptoms. So look for clues of just cough, maybe nocturnal cough in the supine position, perhaps a patulous esophagus, something kind of dilated, hiatal hernia that makes you think about the possibility of reflux disease, and consider, if available, testing with pH probe or impedance, with or without manometry. Those are important things to look at too. If we have a patient and we're thinking about the possibility of transplant, they're going to want to know in the transplant evaluation what the degree of reflux is, because reflux is strongly linked with chronic rejection. It's interesting also to note, this was a small study of just 32 patients with asymmetric fibrotic lung disease, and 15 of 16 reported sleeping with the more affected fibrotic side down. But it's interesting when you see that asymmetry, many times asking patients which side they think they sleep on more than others or start out sleeping on may correlate with the fibrosis, and that may be another clue yet again for reflux disease. So in 2009, we published the first article looking at sleep apnea or sleep disordered breathing in idiopathic pulmonary fibrosis, and we took 50 patients who had ATS criteria confirmed IPF, and they all did sleep questionnaires with Epworth, sleep apnea, sleep disorders questionnaire, and had nocturnal polysomnograms in the lab. And of those, 88% had obstructive sleep apnea as defined by an apnea-hypopnea index greater than 5. And they all had comorbidities that warranted therapy. At that time, when people had an AHI above 5 to 15, you needed a comorbidity with it to be able to treat for Medicare patients. And they did, and interestingly enough, out of that group, 68% had an AHI greater than 15. 15 to 30 is moderate, greater than 15 is severe. And it's out there. Just begin to look for it, whether they have classic symptoms or not. These people were not sleepy. They did not have elevated Epworth Sleepiness Scale scores, so don't dismiss it as a possibility just because they're not sleepy. They may have fragmented sleep, they may have nocturia that we tend to blame on the prostate, but it may not be all the prostate's fault. They may not fully be refreshed at nighttime. They may have nocturnal cough. Reflux can be aggravated by sleep disordered breathing through occlusion of the upper airway, creates a negative pressure in the chest, worsens reflux, especially in the supine position at nighttime. So another low-hanging fruit, looking for sleep apnea, sleep disordered breathing may end up helping reflux, and actually there's data from the Journal of Gastroenterology from the mid-2000s that put pH probes down patients and showed that reflux was abrogated in patients with sleep apnea when they were treated with CPAP. And at the same time, by treating their sleep apnea, you may be helping them breathe better, have less of a hypoxic insult at nighttime, and less revved up mediators. More research needs to be done, but again, a low-hanging fruit and a reason to treat. Many of these patients have comorbidities that necessitate treatment for sleep apnea, like heart disease. So another interesting finding that we see as a pulmonologist, I'm a sleep pulmonologist too, is that this is not surprising to me, but for many people who don't read nocturnal polysomnograms, it's surprising to know that in some studies, the maximum SAT decline, the dips at nighttime, can exceed maximal exercise desaturation in these patients as well, which is surprising. So think about sleep at nighttime. Let's look at their medications, substance use. Goodness knows we've seen a lot of information about and worries about vaping over the news. And actually I saw a patient just last week who was vaping instead of smoking, so we had to go through and work through his denial about that vaping could be a problem, and that's a hard thing for people to quit. Ask about over-the-counter medicines. I'm always surprised. I'm in the South. I'm in Nashville. I'm surprised about how many people put Vicks into their nose regularly or even eat Vicks Vapor Rub. I know, but it's surprising, and be sure and ask about those things and other over-the-counter medicines. Pneumotox.com, great resource. I know many of you probably realize that, know that. Smoking history can give you other potential clues to other interstitial lung diseases, and we always want to touch base on illicits, especially cocaine, and can get a not too uncommonly emphysema pattern with that. Take a good history about their job or about the spouse's job, because they may be bringing home all of that dust and debris on their clothing. Do they have pets? I'm always amazed at how many times I ask that, but the bird doesn't actually come out until the second, third, or fourth visit, and then the bird gets mentioned. And then I'm usually surprised because that only happens maybe once a year or twice a year. Many times the people that we suspect hypersensitivity pneumonitis in, we never can quite find what that antigen may be. We always ask about down in pillows or comforters or cushions or coats, hot tubs, humidifiers, any kind of water damage or mold too. And make sure you ask about the air ducts in the air conditioning system. A lot of times people have older homes. They may not have had the fixed filters that are in the AC cleaned down, and you'd be surprised what's there. Now, whether or not I can prove that that's the problem, I really can't, because I don't have the resources in my area to be able to do that. But basically, if there's mold or any kind of organic antigen floating around the air in the home system, just have it cleaned out. I think that's probably true for anybody. We have patients do a questionnaire going over their work history and exposure history. Some is for us to try to understand a little bit better suggested connections, and others are absolute connections with interstitial lung disease. So obtain a complete history. If you do the work on the front end, it makes it a whole lot easier with subsequent visits. Whether that's putting these kind of patients, if that's a suspicion, at the end of a morning or afternoon clinic where you know the time is going to go long and bleed in, or setting aside a little bit more time for them. There are extra codes for time spent. So physical exam, most of the time doesn't give you many clues except for the bibasilar crackles, and you've got to make sure you listen deep down into the deep sulci. I'm looking for signs that may suggest more of a familial component with clubbing. Autoimmune disease in red are signs of pulmonary hypertension. Laboratory can give us various clues to cirrhosis, vasculitis, myelodysplastic syndrome with short telomeres, to autoimmune disease or to other diseases that cause shortness of breath. But your only sign of cirrhosis may be low platelets. They may have completely normal liver indices, so I want you to remember that one. Pulmonary function testing, most of the time we see restriction. We may see preserved lung volumes when we see a combined pulmonary fibrosis emphysema picture, and then we'll think about these diagnoses when we see obstruction. Don't forget about aging. We lose about 20 to 30 mils of vital capacity per year, about 1,800 over the course of our lives from 18 to 85, and then our body habitus with other diseases, enlarged heart, all those things can contribute a little bit to restriction. John's going to go over genetic associations and kind of tease through that. But at this point, we don't regularly check it in sporadic patients. We don't necessarily regularly check it outside of a study in familial patients, in patients who have risk factors like premature graying, cryptogenic cirrhosis, aplastic anemia. Then we may think about checking a telomere length because these costs are out of pocket for patients. Insurance won't cover it. We probably know a snippet of genes, so checking for the precise gene is not going to change my management. But I have had families that were suspicious for short telomere syndrome say, well, I really want to know what's going on. So in that case, I'll check a telomere length. You can get a 2-cell granulocytes and lymphocytes for about $400 with repeat DX. The rest of the testing can run into a few $1,000s, so we don't regularly do that. So walk studies are extremely helpful. They help me by knowing how to titrate their oxygen. So if they desat on a walk study, I'll have the nurses walk them again and retitrate them for oxygen. Then the next time that they come back to clinic, we'll walk on that retitrated oxygen level. Say it's 3 liters. If they desat on 3 liters the next time, I know that they're progressing. So that helps me to look at the nadir, to also look at if I'm increasing flow rates. If their distance is lower, I know their velocity is going down because distance divided by time of 6 minutes is their velocity. So that's my marker for how fast they're walking as well. We use the ATS guidelines for diagnosis. As pulmonologists, what we usually get is we get this injury pattern on high-res CT, and we work backwards from the injury pattern. We're trying to exclude autoimmune disease, drug toxicity, environmental exposures for IPF, and we are in the process trying to classify this as a progressive fibrotic disease to meet those criteria. We want a high-resolution CT. This can be very variable in the community. The things that we don't see usually are prone positioning and expiratory images. When you flip patients over prone, you open up those atelectatic areas or have gravity take fluid south toward the front of the chest when you flip patients over, and that can help get rid of mimickers like atelectasis or fluid of fibrotic changes or increase in the interlobular septal thickening. We get expiratory images because if we see air trapping in 3 or more lobes, that may suggest a small airways disease and put us in a little different category like chronic hypersensitivity pneumonitis or maybe even reflux-related lung disease or autoimmune related lung disease. So we tease out the categories of injury pattern on the high-res CT with the help of our chest radiologist. And if you don't have dedicated radiologists in the community, think about sending your patient to see us at ILD centers. We are happy to help with this. This is what we do, and we want to have a shared relationship with our community providers. So just to remind you of the typical features, and you'll be seeing more of that as time goes by, of idiopathic pulmonary fibrosis with the reticulation, honeycombing, basilar predominance. Probable UIP is essentially similar with the absence of honeycombing. We don't think about biopsying those patients as much as we used to. It is not mandatory to biopsy the patients with probable UIP. And patients with this HRC diagnosis were actually included in some of the standard of care clinical trials for IPF. So it's appropriate when you've ruled out autoimmune disease, drug toxicity, environmental exposures that suggest an alternative disease, and you have an age-appropriate patient to think about treating them and not necessarily going further. So that's a discussion we generally will have in our multidisciplinary conference. But we take biopsy very seriously. We do a lot of cryobiopsies where we are, but that's mainly because we have the interventional pulmonologist with expertise to do that, who can get out 5 millimeter to 10 millimeter sample size, and we have great pathologists that are very comfortable with that too. So classic features, and you'll be looking at this a little bit later, of UIP, with our images showing the starred one, especially of the fibroblastic foci, which we think is the sort of leading edge of fibrosis. The American Thoracic Society created a nice little box here from the guidelines to help us understand, once we decide the HRCT pattern and histopath pattern, if patients have that done, then we can sort of figure out where they fall into things. And we utilize the multidisciplinary conference to help sort out those radiologic and histopathologic patterns, as well as figure out when we have areas that are in the gray zone of non-IPF or borderline, what that may be and what our best management strategies may be for that patient. So do think about referral to an IPF ILD center, at least in this 2011 article is suggested improved survival. We have a lot that we can add in addition to our community physicians, not just help out with experts in HRCT and pathology and putting the whole diagnosis together as a team. We work very hard with nurse educators to educate these patients about their disease, any therapies. We have support groups for ILD in general. Can help them get linked in either at our centers or locally into pulmonary rehab, and can really help you assess and transition those patients for lung transplant evaluation. Centers also have the support of palliative care physicians and hospice, and with the social workers and nurse practitioners who can look at their particular county and say, this is what's available in your county and these are the resources, so that when the time comes, they can plan. And I tell patients, there's a lot of hesitancy to discuss palliative care or hospice, sort of end-of-life things. So I try to relate this to money management. We talk about life insurance. We talk about wills and trust. We try to get all of those things in order, long-term care insurance. We try to get our money in order. So if we're gonna put that much attention to our money, then we need to do that to our own personal health too, and plan for that. So this is no different. This is just planning for the future. There are lots of different resources for patients and providers. Clinicaltrials.org will give you an idea of what trials are going on. Feel free to email the centers that are closest to you in ILD or IPFs to see what their latest trials are. They are happy to tell you about that. So key points, just to reiterate, that we focus on during the history: set expectations, get the chronology of the presentation and their symptoms, go over risk factors, as well as a thorough rheumatologic disease with exposures, touch on the comorbidities, family history that may suggest more of a genetic component to that, physical exam mainly to look for genetic clues, autoimmune disease, and pulmonary hypertension, looking for compatible imaging to categorize the patient, and pulmonary function testing, as well as walk data to put the whole picture together. Because together with the patient, we're both detectives. And I try to tell patients we are in our infancy in understanding these diseases, but each year there's an evolution in knowledge. And be prepared, because we may call this something different. We may manage this differently. And if we do, you'll be the first to know about it, and we'll get things changed and adjusted as we learn more about your particular disease. Take 2 visits, take time with the patient, set those expectations. The more time invested up front, the better. And then always think about referring to an ILD center, because unless we continue the research, we'll never be able to move further in the field. And that's it. Thank you so much.